again, it's a pleasure to meet you and to share a little bit my point of view and a practical approach to evaluate these patients. I have been working for more than 2 decades with Dr. Ventura, and it has been a pleasure to take care of his patients. Now we'll see what are we doing to evaluate them. So in our hospital, we have established a very nice follow-up of especially neuromuscular patients and severe patients requiring scoliosis. So from the neurology department, we got very nice diagnosed, very deep studies of our patients, and a good follow-up, and also with the rehabilitation treatment. Always if symptoms, respiratory symptoms or other symptoms appear, then we started to follow up these patients from the pulmonologist point of view, and just deciding if any patient requires respiratory support previous to the surgery. One of the main goals is just because this strong surgery has a risk, so we don't want to have a patient with a very nice straightforward spine, but getting a tracheostomy or getting a severe complication and facing several days in the hospital. So that's a major point. So let's focus on the clinical assessment and the exams required for these patients. For me, I think that we are very used to look at X-rays, to functional respiratory numbers, etc., but the clinical assessment is important. And especially for those patients that are not collaborative, they are not going to blow. We are just going to have an X-ray or a CT scan. So for me, it's important to know something has happened related to respiratory failure, previous admissions in intensive care, previous post-op complications, or simply, have you had atelectasis after a simple cold that you get sick for 3, 6, 8 weeks, coughing, and getting X-ray, getting antibiotics, and you don't clean rapidly this mucus? So something is saying you that something is wrong with your cough system, or that your muscles are weak. Another key questions are related to nocturnal hypercapnia. If the patient has a neuromuscular disease that is causing that hypotonia mainly during the night, and his spontaneous breaths are not strong enough during the night, he's going to be hypercapnic. So we should ask in the morning, is the patient irritable, has headaches, is he sleeping during the day? Some of younger patients complain of secondary enuresis, a patient that was really capable to control the sphincters, now is not able to control the sphincters, urinary sphincters. So this could be symptoms that something is wrong of this patient during the night. Another symptom could be that the patient is awakening more times, not just for being moved or changing the position. It's not just 2 or 3 times that is very common in neuromuscular patients. It's just the patient every hour he or she is awake and is demanding the parents to be there and claiming for something. So it means that the sleep of the child is not good. So it could be a concern about this nocturnal hypercapnia. Obviously, as doctors, we love to have objective data that is very clear. You have numbers. We know that doing functional respiratory tests, you have more information than with an X-ray. And we are looking at the vital capacity. We are concerned about those patients who have a vital capacity below 60%. But especially those who are below 40% are at high risk of needing respiratory support. Perhaps now they're stable, but because they are lucky, they don't have flu, they don't have infections, and then they are avoiding destabilization. But with the surgery, we are doing elective destabilization of this patient. So at that moment, if we are not prepared, a patient who seemed to be well, doing well, now cannot be weaned from the ventilator and ends up on a tracheostomy. So be aware of those patients with a vital capacity below 60%, especially below 40%. The mechanism of cough, it's crucial to remove secretions. It's very important. So, and we know that can be easily measured with a mini Wright test or with other more sophisticated devices. What we are is measuring is the strength of the muscles to provide a proper cough. In adults' values, we know that being below 270 liters per minute is abnormal, but it means that we can face problems, but especially, so it's important just to be and to measure, because if we detect this, it means that we should provide treatment for that. It means we should assist the cough. We should provide with the respiratory therapies, with the nurses, we should turn on which devices we are talking about. Obviously, we are using a lot the blood gases. In intensive care, especially adult intensivists are so in love with the arterial blood gases. This is the best quality of PaO2, it's obvious, and we have the better value of PCO2. What we are getting with capillary blood gases, we had a good measurement of the pH, we have a very bad measurement of the oxygenation, but we can look at the pulse oximetry. The PCO2 values are not very good, but we have the bicarbonates. What is telling you the bicarbonates? If a patient has chronic respiratory failure, just after 24 hours, the kidney starts to compensate the pH. So it means if your bicarbonates are higher than 26 millimoles per liter, and you are not taking furosemide, probably you have a compensation of respiratory hypercapnia. This is a last minute check. Obviously, if we are doing nocturnal pulse oximetry, if we are doing polysomnography with tidal CO2, we will be able to detect earlier these problems. It means that if you don't have polysomnography, if you cannot perform nocturnal pulse oximetry, at least you can identify patients without clinical symptoms, but they're very, very close to have problems with the respiratory system. And this is because the kidney is starting to compensate the nocturnal hypercapnia. So that's important because this helps you to identify those patients asking for non-invasive respiratory support. What are we doing? We are looking at these patients every 6 months. We have an emergency room protocol for neuromuscular patients when they're having colds. We have, for those who fulfill the criteria that they need non-invasive ventilation, that they need cough assistant, we have a home ventilation program to start to train the parents and to transfer these patients at home with the proper treatment. We know that we should help the inspiratory muscles with the non-invasive ventilation. We should help the expiratory muscles with the cough assist, manual or mechanical. It's difficult to improve the valvular function. When you have a bad valvular function, usually is a contraindication to the use of non-invasive ventilation. It's difficult to use cough assist, so it means that usually these patients have very bad prognosis, as it happens in adults with sclerosis lateral amyotrophy. So let's have, which are the tools we need? So for those patients who need respiratory support, we need a home ventilator, very simple, very cheap. In order to provide proper cough assistance, we need the family to be trained. And we just need a resuscitation bag and a well-trained family just doing abdominal chest compressions after the insufflation with the bag. Obviously, if we have devices for suctioning the secretions of the mouth can help, but the most important thing for us, I think, is the cough assist device. The cough assist device, called also insufflator or exsufflator, is especially well designed to help the cough, to assist the cough in neuromuscular patients. Other options that we can do to improve or increase or keep maintaining the lung vital capacity of our patients, using them in spirometer, it's important, and also again using, as I saw, the air stacking, using the resuscitation bag to do these insufflations and keep the lung open. That's pretty interesting. Obviously, with the scoliosis surgery, these patients are going to improve a lot, but the use of non-invasive ventilation in very young infants can help to keep a very stable thoracic cage. We are using in spinal muscular atrophy type 1 and type 2 severe forms, we are using prophylactic non-invasive ventilation to prevent the shrinking of the intercostal muscles. Obviously, this Vector device, it's crucial for infants very, very young that has a very small thorax. Again, we shouldn't forget one of the major reasons for respiratory failure is the bad or extremely bad management of secretions of these patients. Cough assistance, chest physio, and again, insufflation, exsufflation with devices, it's very important. Years ago, this consensus of specialists said that the use of cough assist was the first line intervention in patients with spinal muscular atrophy type 1 and 2 in order to prevent admissions in the hospital. We have been using for years, and I can tell you that nowadays it's not very common having patients admitted in the PICU or in the general ward for this, for needing oxygen or antibiotics because they have a respiratory infection. Usually they can do that at home. So to end and wrap this session, I think that an appropriate evaluation by a pulmonologist with experience in home ventilation is mandatory for these patients. If we don't have respiratory therapies, then the doctors and the nurses should have the proper respiratory skills to manage this, to provide respiratory care with cough assistance and instaurate the non-invasive ventilation. So, and this should start before the surgery. So years ago, we had the problem in the unit, we couldn't wean the patient from the ventilator, and we were at high risk of tracheostomy. Even we had some bad experience of patients who got a tracheostomy. Luckily, after 2 or 3 months of recovery at home, we could switch back to non-invasive ventilation. But nowadays, it's not happening anymore because we are doing all this preoperative management of our patients. Thank you very much for your attention. I will be very pleased to answer whatever the questions related or comments related to this question. Thanks. Thank you very much.
Thank you, Dr. Pons. I would like to ask all panelists to turn on microphone if want to ask you some questions, because when we didn't see or didn't hear when someone want to ask you something. We are waiting for questions.
Mm-hmm. No, we understand that in Serbia, probably being as we are a Mediterranean country, it can be a nap time, so it takes time to be awake.
have a question for Dr. Pons.
Okay.
Hello, I'm Marko Aleksić from Belgrade
Thanks, Marko.
Institute Banjica. In your opinion, what is the lowest vital capacity that would be a contraindication for scoliosis surgery in children? What is the value that is something we can take for surgery?
Okay, I would say that there is no contraindication. Because if you are able to substitute the lung with a proper non-invasive ventilation, stable, we know that John Bach, that we are following most of the recommendations of John Bach, the rehab doctor in the States. He has several spinal muscular atrophy patients with zero vital capacity, 24 hours per day with non-invasive ventilation. So it means that when the patient is below 40%, he is at risk of having nocturnal hypercapnia and having respiratory problems. Below that, it's clear that it can happen the whole day. So it means if you start non-invasive ventilation when he is around 50%, 40% of vital capacity or facing clinical problems, this patient is suddenly stabilized for years. It means that with the proper treatment of management of secretions and the proper treatment of non-invasive ventilation, this patient is living for decades without any problem. Even though then, if you got the surgery of scoliosis, you get an stable vital capacity. At that moment, you are at 30 or at 20, it doesn't matter. So because you are having the proper treatment. Nowadays, we're able to provide, as Dr. Bach is doing, 24 hours a day non-invasive ventilation. So we are using mouthpieces during the day and nasal mask or total face mask during the night. And we have a few patients that can do that. Obviously, if the patient is not comfortable and is not safe, those patients should be switched to tracheostomy. But it doesn't mean that the patient is contraindicated to the need of scoliosis of the surgery, because for the anesthesiologist can maintain easily this patient stable during the surgery. It's the problem for the intensivist who should win this patient. If the patient is prepared to be weaned to non-invasive ventilation, it's pretty easy. If the patient already needed tracheostomy, no need to be worried of that. You can wean to a home ventilator. So for me, the question is that if the hemodynamics, the heart are okay, and you are treating the respiratory insufficiency, you can do that, no matter the numbers. It's a global condition. If there is no other contraindications, but usually we identify these patients earlier than being below 30% of vital capacity. I hope so.
Thank you so much.
Thank you.